Thank you again. Again, it's a pleasure to be here. I'll try to erode some of the delay that we had, and I'll try to entertain you a little bit on an issue that, by surprise, has been hardly mentioned so far. I think it's a world record not having talked about COVID for an entire day of any scientific meeting. So, if I could get my slides, please. So, it all started 2 years ago. It seems like it's been ages, but 2 years ago, it was a terrible time for all of us, some areas more than others, but in that eye of the storm, everybody was talking the same language that we talked. It was pretty incredible. Everyone was becoming an expert about cytokines, about inflammation, about cytokine storm, all words that we kept repeating in our daily practice. So that's when we became popular. I mean, my mom finally understood what I did for a living. And that was something. It took many years and a pandemic to get to that. So that's when autoimmunity and rheumatology in general became central to the discussion. There's a very nice poster that I was discussing earlier at the e-poster station about the fact that patients with rheumatoid arthritis basically know nothing about their disease. And the general population knows a little bit less than that. So this is what I'll be talking about. First, a brief look at the actual pathogenesis that is shared by COVID-19 and autoimmune rheumatic diseases. Then talk about vaccination, because that's the flavor of the day. I'm sure everyone here is flooded by emails of patients asking, should I do this, should I do that, what should I do with my drug, and so on. Then we'll look a little bit at autoantibodies, because that's the easiest part to look at for autoimmunity in COVID-19. And finally, we'll look at the shared treatments between the different conditions. Yes, as I mentioned, we became popular because everyone was using the same words, the same buzzwords, especially in terms of cytokines. Everyone became an expert on IL-6. The news were talking about IL-6, interleukin-1, and TNF-alpha, and everyone was talking about the cytokine release syndrome or cytokine storm for the media. And the same cells that we used to talk about, NK, T cells, myeloid cells, particularly dendritic cells, became the center of the world. And then when the first genome-wide study came up, we were even more surprised because we saw some association with DRB1 and B27 HLA alleles that we are even more familiar with us and that were associated with a more severe COVID-19. And that's when we performed, actually, Francesca Motta, who's in the picture there, performed a systematic literature review, finding out that basically all possible autoimmune and rheumatic diseases were associated with COVID-19. I'm sure you all remember that. It was a time in which every drug was tried for COVID-19, every associated condition was reported with COVID-19. And that happened also for autoimmunity. Some remained until today, like what used to be called Kawasaki-like, and it's now MIS-C, Guillain-Barré-like syndromes. Arthritis, we actually had a couple of de novo psoriatic arthritis cases happening through after COVID-19. And then that's when glucocorticoids became the buzzword for treatment. And in the infodemics that came, the flooding of publications and preprints about COVID-19, autoantibodies and autoimmune diseases started to be described. This is what's been described in the earliest phases. And you can see there that any possible autoantibody has been described in the case of COVID-19, in some cases also associated with a more severe form, and we'll see a little bit of that a little later. But as you can see, anything from type 1 diabetes to specific vasculitis to antiphospholipid syndrome or even SLE were reported in association with COVID-19 and with a plethora of autoantibodies, all with different manifestations. Of this, I I picked one, which I think is particularly fascinating, which are antibodies directed at type 1 interference. Why is that? Because we've been knowing for quite some time now that type 1 interference are central to the antiviral immunity. And particularly, innate immune cells are particularly sensitive to interferon in the fact that they enhance the antigen-presenting function, thus becoming pivotal to the response to the virus. And that's why antibodies neutralizing type 1 interferon were found in over 10% of patients with life-threatening manifestations of COVID-19. And these were amazing, and some amazing work done by my good friend Paul Bastard. He did, in which he found that this was most common in men. The sex ratio was evident since the earliest phases of the pandemics, and that autoantibodies were actually present before the infection by SARS-CoV-19. So as if to say that the additional effect of the viral infection, the cytokine release syndrome, and the pre-existing and de novo autoimmunity could play a role in the severity of the condition. What about SARS-CoV-2 vaccination? Well, we've been repeating this all over and over and over again, but definitely I think that we're all convinced that the SARS-CoV-2 vaccines are the safety and the benefit of the vaccination is extremely beneficial to the patient with rheumatic diseases, although we have to be entirely transparent in terms of data. Some rare new onset immune-mediated complications have been described, in most cases in which causality is really difficult to determine. And the third case is that the flare of autoimmune diseases following vaccination, fortunately, has been quite rare. And that's why, if you look at the literature, you will find a whole bunch of conditions that appeared after the vaccines, again, in which the causality of the vaccination is very difficult to demonstrate, particularly since there's no data about the pre-existing serology. But then we looked at our series. We vaccinated about 1,000 patients. We investigated 287 with different conditions. We used the Moderna vaccine. And right away it was pretty clear that systemic sclerosis patients and dermatomyositis patients and systemic lupus erythematosus patients did have a lower IG response to the 2 doses of Moderna vaccine. And we right there found out that that was all about mycophenolate. Mycophenolate was actually the reason why these patients, not the condition itself, was the reason why these patients were responding less and later compared to patients taking any other drug, including biologics. And we also reported that the threshold was 1 gram per day, meaning that patients with any condition taking more than 1 gram per day of mycophenolate mofetil were at higher risk of not mounting an immune response to the vaccine, and they also had the delayed peak in antibody titer. Nonetheless, these patients also had less cytotoxic activity. Although it was not entirely overlapping with the reduced IgG response, these corresponded in the majority of cases, and still the cytotoxic response was conserved in virtually all the other categories of patients. While disease activity was flared only in 9 out of 219 patients within 4 weeks, and 21 patients out of in the 16 weeks following the second dose. I think, to me, these look like data that any possible series of rheumatic patients may experience regardless of the vaccination. And to kind of support my conservative view is the fact that antibody titers following vaccination were not different in patients with flare versus patients who did not experience a flare. What about interstitial lung disease? I think that since the very first phases of the pandemics, we were quite surprised to see these pictures in the patients that had severe COVID-19, because these pictures are familiar to those of us doing connective tissue diseases. You know, multifocal ground glass opacity and consolidation, organizing pneumonias are something we look for in patients with severe interstitial lung disease associated with connective tissue disease. That's why autoantibodies associated with connective tissue diseases came right to our minds. And that's why, again, Maria De Santis, who's in the picture here, did a study in 35 hospitalized patients and found virtually all myositis-associated autoantibodies in these patients. Of particular interest were MDA5 antibodies, because MDA5 autoantibodies were found also in patients with COVID-19, severe COVID-19, without evidence of dermatomyositis. And it's interesting to see that these patients with MDA5 dermatomyositis generally don't have a frank muscular involvement, but they have a pretty overt interstitial lung condition, which is reported in the picture here. These are patients, it's a subgroup of myositis patients with MDA5 that have a pretty strong lung involvement that you see pictured, especially on the right-hand side there. And finally, shared treatment. That's why we became expert. Number one, it was glucocorticoids. And I think that the curve of our understanding of glucocorticoids very well represents what happened during those months. That's the beginning phases. 3 major authoritative sources were very tepid about the use of glucocorticoids: The Lancet, the Surviving Sepsis Campaign, and Up to Date. All of these were based on data from the flu and of data from SARS-CoV-1, the first SARS that came along about 10 years ago. That's when glucocorticoids did not prove beneficial and actually proved a little harmful. That's why the advice at the beginning was against the use of glucocorticoids, but then larger studies came, and eventually we were convinced that the use of glucocorticoids, also depending on the dose, in patients who were impaired in terms of respiratory functions and that needed non-invasive or even invasive ventilation, could benefit in terms of survival and in terms to the possibility to get off the ventilation when treated with dexamethasone. However, we started, at least where I practiced, people started to use glucocorticoids for anybody who turned out to be positive for SARS-CoV-2. And that was actually a mistake. We were able to prove that patients who were treated with glucocorticoids before developing the respiratory symptoms and before being admitted to the hospital did not have any amelioration in terms of the outcome. So that treating earlier, in these cases with glucocorticoids, led to no efficacy, no advantage whatsoever. And that's something that we tended to communicate to primary care physicians throughout the country for many, many months. Then came tocilizumab. Tocilizumab, since the very first phases, especially in China, then also in our country, became a major player. And that's when several studies came with different primary endpoints, unfortunately, different type of populations. Definitely these meta-analyses that included especially the heaviest study, which is the recovery trial, which, as you can see, included more than 700 patients treated, 600 patients treated with tocilizumab, had showed that tocilizumab did lead to an amelioration of the outcome of patients with COVID-19. In our own experience, this was indeed true in a way, but it was true especially in patients that survived more than 5 days. When we treated patients that had a life expectancy lower than 5 months, tocilizumab did not make any difference. When patients were destined to be surviving longer than 5 days, tocilizumab did make a difference, as you see from the survival curves that start drifting apart after the 5-day threshold, leading to a 60% advantage in terms of survival. Then we used artificial intelligence to try to determine what the mechanism, what the predictors of the response and the survival associated with tocilizumab treatment were. And to our surprise, we demonstrated that AST level, transaminases, were the #1 determinant of survival when treated with tocilizumab. If you ask me why that is, I can only imagine that probably the multi-organ failure that starts to happen in this type of patients, including liver damage, which since the beginning seemed to follow LDH and other biomarkers of advanced disease could be represented here. And last is anakinra. Anakinra, as you know, is a receptor antagonist that blocks interleukin-1. It's used largely in autoinflammatory diseases. This is a Greek-Italian study we had the fortune to participate to, a multicenter study in patients who had not been yet subject to a mechanical, non-invasive or invasive ventilation that had hyperinflammation. In these patients, the regular dose, subcutaneous dose of anakinra for 10 days led to a significant improvement in terms of the risk of progression to severe respiratory failure or death by 2 weeks. And that's something that definitely made a difference in our patients. And that's probably something that should be used earlier in the phases of COVID-19. So I'm done. What are the lessons we learned from COVID-19 that we could apply? Well, number one is that autoimmunity is everywhere. Everything is autoimmune until proven otherwise. The second lesson, allow us. Immunology and rheumatology is all you need to know about most of medicine. Infectious diseases do require all of our attention, and we probably need to collaborate more with infectious disease specialists. Number four, our patients know how to behave in a storm. I think it's shared experience that very few patients interrupted their treatment during the pandemic. And that means that we did a very good job at teaching them what to do, teaching where to find information. And that's something that, for example, diabetologists could not say today. That's something that I think we should congratulate all of us for that. We can most certainly adapt. We started doing telemedicine and all that. We must rethink our rheumatology practice. The rules of science, like the glucocorticoid story taught us, cannot be overlooked. And finally, like we heard about rheumatoid arthritis, like we heard for osteoporosis, like we heard throughout the day today, timing is essential for any treatment. And in the case of COVID, that's even more important. There's not universal treatment for COVID-19. There's a specific treatment most recommended at any specific stage of the disease. And with this, again, I thank you very much. And again, the lovely people I'm fortunate to work with in Milan. Thank you very much.